So my name's Wolfgang. I'm a pharmacist at Trinity Health Oakland, used to be St. Joe's. And I am the second year critical care pharmacy resident. So this is all general medical related information. Anything that's, coming, any parameters coming from the physician at the transferring facility would supersede anything that I tell you here. You should be clarifying any of the orders from the transferring facility. So that means things like goals of therapy, titration parameters, hold parameters. They should be providing you all of those when you're leaving the facility. So all of those orders come from a physician. Next medications we'll go into are ones that are going to decrease blood pressure or decrease heart rate. So we talked about the ones that increase it. So now we're So the first one here is Cardene. So I'm going to call it Nicardipine because it's easy to get the brand names mixed up sometimes. But you might also hear it called Cardene when they give you a report. So just make sure you're being aware of that because there's also Cardizem, which is Diltiazem, which is similar but very different. So this is a dihydropyridine calcium channel blocker. It causes peripheral vasodilation, so it's opening up the blood vessels. Typically used in hypertensive emergency or other times that we're trying to acutely manage blood pressure. So this could be acute ischemic stroke, subarachnoid hemorrhage, intracranial hemorrhage, aortic dissection, things like that. All right, so goals of therapy for nicardipine and a lot of these blood pressure lowering agents, they can be very specific to whatever we're using it for. So for these ones, it's going to be really important to confirm with the transferring facility what we're using it for, what their goals are, because they might have a range of blood pressures depending on what we're using it for. So the acute ischemic stroke, if they've had it thrombolytic, then we might be targeting less than 180 to maybe 160 or 140. So it's going to be important to talk to them and figure out where they want that blood pressure. Sometimes they might want it 160 to 120. So it can be very variable depending on the indication, depending on the provider and what they want. Dosing range is going to be between 5 and 15 milligrams per hour. So just make sure that you're, setting up your pump rate. There's a lot of different units for all of these medications, milligrams per hour, micrograms per kilogram per minute. It can get really confusing. So just make sure you're double checking with it. Onset of action is within minutes, but it can peak within like 1 to 2 hours. So it's not as quick. You're not going to see the effect as quickly as with some of the vasopressors because it can take a while to take effect. It can also take a while to wear off. So it can tend to accumulate, which can cause blood pressure lowering over a longer period of time, even after it's shut off. So that's why we want to be careful with titration with it. So you should be checking the blood pressure every 5 minutes, titrating every 5 to 15 minutes. This will depend on the transferring facility. So you should get instructions from them how often you're to titrate it. So some of them might say every 15 minutes. Some of them might let you do it a little quicker. So when you do titrate, you'll increase it by 2.5 milligrams per hour. Usually you won't be titrating it down, but that's something that if the facility does give you the order to do, then you could do that once it starts to get too low. If it starts to get below their range, then I would give them a call and see what they want you to do with it. So adverse events, tachycardia can be a big one. It's kind of reflexive. So when we're bringing the blood pressure down, sometimes we'll have an increased heart rate to kind of make up for that. Hypotension, obviously, it's a hypotensive angina, and then flushing is another one that we can see a lot. So they'll get red in the face. This could just be a side effect of the nicardipine. And again, blood pressure monitoring, heart rate will be the things we'll be looking for. So important thing with this is just to make sure that you're confirming what the goal of therapy is, because it can be different depending on what you're treating. All right, next, nitroglycerin. So this is another vasodilator. We use this in acute decompensated heart failure sometimes. Angina, we might start a patient on a nitroglycerin drip or a hypertensive emergency. So again, this is case specific, so they'll have different goals to where you want to lower it to. If we're using it for angina, it might just be resolution of symptoms, so they might not even have a blood pressure goal for that. So it's difficult to titrate if you don't know what you're looking for, so make sure that we're getting orders for that. They might have a blood pressure goal in addition to resolution of angina symptoms. So we just want to make sure that we're confirming that before we're leaving. Goal range, 5 to 200 micrograms per minute. And then onset of action is usually pretty quickly. Duration of action is 3 to 5 minutes. So we should see a difference pretty quickly when you do alter it. So when you do increase the rate, it'll be by 5 micrograms per minute. You can do this usually every 5 minutes because it is pretty quick acting. So again, with this one, hypotension is going to be one of the big ones. You can also see some bradycardia. And then with nitroglycerin, we can also see flushing similar to Nicardipine, but for different reasons. And then obviously we're going to be monitoring blood pressure, heart rate. If it's for angina, we'll be monitoring signs of chest pain. Okay, so next is Nitropresside. So we don't use this one very often, but you might see it used. It's kind of fallen out of favor for other agents, but in certain situations that might be what we're using. So use it for acute decompensated heart failure, or in some of those acute blood pressure management. So aortic dissection, ischemic stroke, things like that. Again, so goals of therapy are going to be specific based on what you're using it for. They'll be, the same as with Nicardipine, depending on the indication, depending on what the provider wants the goals to be. So I have seen a lot of variation in goals, so that's why I don't really want to give you a specific one. So just make sure that you're confirming that before you're leaving. Dosing range, so 0.1 to 3 micrograms per kilogram per minute. It can go up from this. So if you do get orders, that you can increase it beyond this. It's not wrong, but we see cyanide poisoning at higher rates. They usually only limit it to like 10 minutes. So that's why I gave you this range. If they do give you something higher, it's not wrong, just be aware of that. Onset of action is pretty quick. Duration of action, it'll subside at least after 10 minutes, but maybe quicker. So again, checking blood pressure every 5 minutes. We can increase by 0.1 microgram per kilogram per minute. And then we'll usually leave it the same if the goal's met. So this one can cause some pretty severe hypotension if it's dosed too high. So be very wary of that if we're going up in the dose, especially if they're asking you to go beyond that 3 micrograms per kilogram per minute. Just be really wary of the hypotension. And make sure if they are having you go higher than that, there's a plan for titrating down if you need to. And then bradycardia can also be kind of with this one. Monitoring blood pressure, heart rate, again, another big one. All right, Labetalol. So this one, it's a alpha beta adrenergic agonist. It's kind of mixed. It's a beta blocker. So it can both decrease heart rate and it can cause vasodilation, so it can decrease blood pressure. So it might be used for either of those. So it's another one that you're going to want to make sure you have the parameters for. They might be targeting heart rate or blood pressure or both. So that'll be important. Typically used for acute blood pressure management, though, things like aortic dissection, ischemic stroke, etc. Dosing range will be 0.5 to 8 milligrams per minute. Onset of action within 5 minutes. Peak effect, this is another one that can kind of ramp up. So you'll see some effect at 5 minutes, but then it'll continue to work. So you might want to be careful when titrating it, not to do it too quickly. And it can actually stick around for a while. It's another one that can accumulate. So with this one, we say to check the blood pressure every 5 minutes. That way you can see if there's any trend in any direction. Our parameters say to titrate it every 20 minutes. That's because of that peak effect and then that long duration of action. So make sure you're clarifying how often to titrate it with the transferring facility. They might have something different. They might have 30 minutes or 15 minutes, but 20 minutes is where you usually settle on. You can increase the rate by 1 milligram per minute. And then just see if they have any instructions on decreasing the rate if it's going down too quickly. Because again, this one can stick around for a while. We want to make sure we're not, overdosing them for the next 16 hours. Adverse effects. So hypotension, bradycardia, obviously. It can have some bronchospasm because it's non-selective. So it does hit beta receptors in the bronchioles. Can have some nausea, some fatigue. So just things to be aware of, not really anything that we're necessarily going to decrease it for. But it could be explained by the Labetalol infusion. And then monitoring blood pressure, heart rate. All right, so the next one, we have another beta blocker. So this is Esmolol. So this one, primarily, we're going to use it for decreasing heart rate. You can use it for controlling blood pressure. One of its biggest uses is in aortic dissection. Most of our patients with aortic dissection will be on this. But they can also use it for atrial fibrillation, flutter, different tachycardias, thyroid storm, et cetera. So another one that has a pretty wide range of indications. So we just want to make sure we know what we're using it for and we know the parameters that they're looking at. So their parameters for atrial fibrillation may be very different than parameters for aortic dissection. So we might be trying to keep it, less than 110, less than 100 with AFib, but for aortic dissection, they'll be keeping it probably less than 60. So you just really want to be aware of what we're targeting, what we're titrating to. Dosage range, 50 to 300 micrograms per kilogram per minute. Onset of action between 2 and 10 minutes, duration up to half an hour after we turn it down. So with this one, we usually titrate every 5 minutes. We can increase the rate by 50 micrograms per kilogram per minute if we're not meeting the goal. And then usually we'll titrate it down by 50 micrograms per kilogram per minute. But again, just make sure you're clarifying what the goals are with the transferring facility, because again, they can be very, very variable depending on what we're treating. So with this one, the biggest one is bradycardia. So obviously that's primarily what we use it for. So bradycardia more so than hypotension, but you can have some hypotension with it. Again, because it does hit the beta receptors in the lungs and the bronchioles, we can have some bronchospasm. And then this one can actually have some extravasation as well. Monitoring blood pressure, heart rate, kind of the same things. And then the last one we have is Diltiazem or Cardizem. So I purposely separated this one from Cardene at the top of the list. This one is Cardizem or Diltiazem. So it's a non-dihydropyridine calcium channel blocker. But this one is primarily used for decreasing heart rate versus the Nicardipine is primarily used for decreasing blood pressure. So usually we'll use this in atrial fibrillation, typically for rate control. So again, depending on the facility, they might have different goals that you're targeting. But the dosage range is 5 to 15 milligrams per hour. Onset of action is pretty quick, but it does have some, kind of some hang time afterwards. So it can last for up to 10 hours after you shut it off. So it's another one that when we're titrating, we want to be careful not to titrate too quickly. So at our site, we titrate it every 30 minutes. You'll still want to be checking blood pressure every 5 minutes just to see any trends. But we usually titrate every 30 minutes to stop from, rapidly titrating up, and then we have a whole bunch of drug on board. So if the goal's not met, we'll titrate up by 2.5 milligrams per hour, and then we'll titrate down by the same amount if the blood pressure is dropping too quickly. Adverse events, bradycardia, so we do use it for targeting heart rate, so that can be a side effect, and that's in hypotension. Monitoring blood pressure and heart rate. That's going to include our medications for decreasing blood pressure and heart rate. We have a patient case here. So a 72-year-old male being transported from the hospital A to hospital B for aortic dissection repair. Per the transferring hospital physician, the goal heart rate is less than 60. So you pick the patient up at 8 o'clock. I don't know why you always pick them at 8 o'clock, but you know. So starting out, blood pressure is 100 over 65, heart rate's 56. Throughout the trip at 8:15, heart rate goes up to 60, blood pressure doesn't change much. And then at 8:20, it's up to 65. So what would you do with the Esmolol here? It's running at 150 right now.
50 mics a minute.
Yeah, 50 micrograms per kilogram per minute. Yeah, so increase by 50 and then check again 5 minutes to see where we're at. Yeah. Good. Next patient case, so a 65-year-old female being transferred from hospital A, hospital B, following administration of tenecteplase for acute ischemic stroke. Per the transferring hospital physician, the goal systolic blood pressure is less than 180, and you pick the patient up at 8 o'clock, and their blood pressure is 155 over 90, heart rate's 110. As you go through the trip, at 8:15, the blood pressure starts to go up, 165 over 95, heart rate 105, and then at 8:20, blood pressure is 160 over 92, and heart rate goes down to 65.
Thanks.
Nicardipine doesn't usually affect heart rate that much, or it doesn't usually cause a drop in heart rate. I would call the transferring facility here, see if there's anything that they want you to do with it. So, so the blood pressure is at goal, where it needs to be. So usually if you're controlling the blood pressure too much with nicardipine, the blood pressure will be, or the heart rate will be going up to compensate. So you'll have like a little bit of a tachycardia when it compensates. So we would leave the nicardipine where it's at, but I would give a call to the facility. Yeah, because probably now from the nicardipine, there might be something else going on.